Welcome, everybody. I am John Hopper, the president of the Fibrolamellar Cancer Foundation, and this is our virtual research series that we call the Evolution of Research and Clinical Care in Fibrolamellar. Today, our topic is current treatment options for fibrolamellar carcinoma. For those of you who have not been introduced to Fibrolamellar Cancer Foundation, welcome. We're a great community, and this foundation's been around for a while. It was founded in 2009 by fighter Tucker Davis and his friends, and our mission's continued over the last 11 years, and it's threefold. One is to find a cure and treatment options for fibrolamellar, is to raise awareness of this disease, and importantly is to connect and support the fibrolamellar community of patients and families. I'll actually include and physicians and researchers. You know, since we were founded, we've invested over $8 million across 24 research institutions. And the key we find, and I think you'll see this today with a fantastic panelist we have, is that we have a mandate. And the mandate is anyone that we invest with must collaborate with each other and share data. And again, you'll see that exemplified when we have the panel. You know, with COVID, is there a silver lining? Well, in this case here, I think the answer is yes, because we're now able to connect the entire fibrolamellar community across the globe. Today, I believe we have every continent represented. And this allows us to do something we've started since 2016, which is we would have live meetings at various research institutions with patients and researchers and medical professionals, which we're continuing now in the virtual setting. So you all get a chance to meet some of these wonderful MDs and PhDs, and they have a chance to answer some of your questions. Importantly, this series continues on April 14th. If you mark this on your calendar, please. Our next one is called Clinical Trials and Future Treatment Options for Fibrolamellar. So go on to our website, fibrofoundation.org. Please register, and you will also find a wealth of new information all the time on that website. Kurt Losart, who is our CIO, continually updates that with information. So please visit that often. One thing I must say, sessions like this is that the foundation provides information for the benefit of those affected by fibrolamellar cancer for informational purposes only. FCF is not a medical provider or a healthcare facility or a research institution, and thus cannot diagnose any disease or disorder, nor endorse or recommend any specific medical treatments, nor any particular medical provider. So today is really for your education and for you to talk to whomever you need to about what's right for you. With that, I'm going to introduce our scientific director, Mark Furth, who will walk you through the agenda. Mark?
Thanks, John. I'm first really delighted to welcome a spectacular panel and Allison O'Neill as the moderator. Allison is a member of our medical and scientific advisory board for the foundation. Her academic affiliations in Boston include the Dana-Farber Cancer Center or Cancer Institute, the Boston Children's Hospital, and of course under the umbrella of Harvard University. Allie is going to lead a discussion with four outstanding clinicians and clinician scientists who she'll introduce. And then about an hour from now, then there'll be a discussion amongst them that she'll lead. And then about an hour from now, I'll come back to field questions and answer them or hand them on to be answered. And please remember to use the Q&A button on your Zoom screen rather than chat if you'd like questions to be directed to the panel members at the end. And I'll do my best to consolidate questions at that point. And hopefully there'll be inquiries after you can see the foundation's information. Email, more than welcome to respond to questions. What we can't do today is respond to specific medical questions about individual patients. But I think you'll still get a tremendous amount of valuable information from this. So without further ado, let me hand this over to Allie O'Neill.
Just going to briefly share some slides with the group. One moment. Hopefully you can all see these. I just want to say, first off, welcome. It's really an absolute pleasure to be part of an event like this. I've been a part of the Fibrolamellar Cancer Foundation for the last few years, and I have been unbelievably overwhelmed with the collegiality, the collaboration, the individuals that have been brought together, united for a particular purpose. There's no doubt that this last year has been exceptionally challenging for everyone, notwithstanding the fact that many of you who have joined us today are actively dealing with personnel in your lives who are very near and dear to you that are ill with fibrolamellar cancer, and we're very fortunate to have you join us today, and we really hope that the information you take from this and glean from this is helpful to you and your families. I wanted to just intro with a very brief number of bullet points regarding fibrolamellar carcinoma. I know that many of you are already familiar with this disease, but in a nutshell, as you know, it's a rare cancer that arises within an otherwise normal liver, at least to the best of our knowledge. The median age at diagnosis is around 22 years, which is extraordinarily unique. That means that the disease really bridges the pediatric end of the spectrum, adolescents and young adults, and all the way through folks into their 30s and 40s. It's unique in that not many diseases span the pediatric and adult spectrum. And I think that brings together a lot of unique perspectives. We don't really know the incidence of the disease. We think it may be 1 to 5% of all liver cancers, but I think what we're learning is that it's probably been grossly underdiagnosed over the years. And so we have a lot to learn from increasing numbers and increasing opportunities to study this cancer in a meaningful way. We know that it's very distinctive under the microscope. It looks very different from all other liver cancers. We more recently know that it's characterized by this fusion gene, or this genetic abnormality, which really sets it apart. And as I mentioned, that fusion gene is the same in pediatrics, it's the same in young adults. And that too makes it a viable population of patients to study. Sadly, there's not really been an identified standard of care. I think that's where we've really struggled. And I know that's where you as patients and families have been probably very frustrated and struggle as well. I think that we, in coming together in this robust environment, have the capability now to really unite as we move forward to better understand the data that is available, which is what we hope to harp on tonight, and then to move forward in a unified fashion to really learn together as a community. That's really the best way we'll be able to better fight this disease. And I think the FCF has been remarkably successful in establishing a growing and engaged research and clinical community, which previously didn't exist in the same robust fashion as it does now. And so I hope you gain some insight as to the few of us that are already on the panel that are engaged in this community, and many, many more that extend past this. It's, as I mentioned, an absolute pleasure to be here today with many of my colleagues. And I wanted to briefly introduce you to those on the panel, and then individually they'll give their 5-minute presentations. So Dr. Raymond Yeung is a professor out of University of Washington. He's a surgical oncologist. Dr. Erik Schadde, and again, apologies if I mispronounce your last name, Erik, but he is an associate professor out of Rusk University. His specialty is surgical oncology and transplant. Dr. John Gordan is an assistant professor out of University of California, San Francisco. And Dr. Jim Geller is a professor out of the University of Cincinnati in pediatric oncology. And so it's really nice to see that we have a span of expertise, both surgical, medical oncology, and pediatric oncology. And you'll see that each can speak to their own expertise, but really focus on the multidisciplinary nature of the care. And that's what we think is really the most important. None of us can operate, and I say operate tongue in cheek, but really none of us can care for these patients alone. We need our surgeons and their surgical expertise, our oncologists and their systemic view of the patient holistically and everything that entails. And we need to have a consistent and constant interchange at every step along the way. And so I think that's really the angle we've tried to take in providing more information during this panel. And so I look forward to hearing from each of our panelists and each of my colleagues. And I hope that it'll be an informative night for you all. We'll start with Dr. Yeung. I will unshare my slides such that he can share his, and we'll go from there.
Good evening. Can you all see the slides and hear me? Great. Well, it's a pleasure for me to talk to you this evening. First of all, I want to thank the foundation for extending this invitation to share with you my experience with regards to the surgical treatment of this disease. To be accurate, my colleague Kim really was supposed to be the keynote speaker here, but she is currently in the operating room working on a very challenging case, and I'm delighted to step in her absence. So I will be actually providing you with my interpretation of her slides. So as Dr. O'Neill said, I'm from the University of Washington. I'm a liver surgeon. I treat patients with fibrolamellar cancer who are over the age of 18, whereas my colleague, Dr. Really, treats those under the age of 18. That division is totally arbitrary. Let's see if I can. So, as a surgeon, when we see a patient with this diagnosis, what do we think of? Well, first of all, we have to make the proper diagnosis. And usually that comes from an astute clinician, usually a pediatrician, who detects something different about the complaints that they may have, and then initiate a cascade of tests, including imaging. It's usually with some sort of imaging like ultrasound, and then from there going to axial imaging like contrast CT or MR that defines that there is a mass in the liver. Even so, in that particular age group, as you've heard, in the young adult, fibrolamellar is still a very rare entity. In the majority of the cases, when we see a mass in the liver in that age group, we think of benign entities. The most common of these would be things like focal nodular hyperplasia, which actually can look a lot like fibrolamellar cancer because they have this sort of classic central scar, if you will, on imaging. So one of the tests that we commonly use to distinguish focal nodular hyperplasia from other abnormalities in the liver is with MRI using hepatobiliary agent, such as EOVIST. As shown in here, this is an EOVIST scan showing that a tumor that does not pick up the contrast and hence is not a focal nodular hyperplasia. Other things in the differential includes adenomas or even hemangiomas. All these benign conditions are actually much more common than fibrolamellar cancer. So at the end of the day, we usually have to rely on some sort of biopsy for the pathologist to then look at it under the microscope and tell us, yes, this is a liver cancer and is consistent with a fibrolamellar subtype. So after the diagnosis, we then find out the extent of disease. Is it just confined to the liver, or has it spread beyond in what we call staging studies? Typically, that would involve a CT scan of the chest, abdomen, pelvis. In some cases, we use FDG PET scan to further identify the extent of disease. And based on that information, we then try to determine what is the best course. So for the next few minutes, I'm just going to highlight some of the things that help us as surgeons determine is surgical resection an option? In other words, can the tumors be removed safely from the liver? So this whole question about resectability, can the tumors be removed, is in constant flux. For the last 20 years, things have changed so much so that the guidelines have changed. And it's complicated. So rather than telling you exactly what is what, the basic principle behind a liver surgery for this particular disease or other cancers is we can take any and everything out as long as we leave enough healthy liver with an intact blood supply going into the liver and out of the liver. So you can see here there are many different segments to the liver, and depending on the location of the disease, we can take out any one or more than one areas of that liver. That decision is best made by an experienced hepatobiliary surgeon. There are a couple of things that are a little bit more unique regarding this disease. Compared to the garden variety of hepatocellular carcinoma, there appears to be a high incidence of lymph node metastasis from fibrolamellar cancer. So as surgeon, we routinely go and remove some of the regional lymph nodes around the liver in the portal tract and the celiac axis area. Obviously, if they're enlarged on the scan, we would take those out as well. That said, it does imply that they have a more advanced stage and hence a higher chance of disease recurrence. Overall, I think the majority of patients can undergo surgical resection for this disease. There are cases which are more advanced. That involves blood vessels. That in itself does not imply that it cannot be resected. Oftentimes, we can take parts of the blood vessel out and reconstruct it. Here's one such example where this is a large fibrolamellar tumor on the left side pressing onto the right portal vein here. And it was invading into the left portal vein, which fortunately, we were able to remove completely and fortunately staying disease-free 3 years later. Other times, the people have reported the use of things like Y90 or yttrium-90 radioembolization to pre-treat a large tumor and shrink it down prior to resection. Like I said, there are many different ways of getting the liver and the tumor ready for resection. And in cases where there are minor sites of distant disease, such as oligometastasis, small lesions in the lung, that too is not a contraindication for surgical resection. After all, that is in part because there are no real effective systemic therapy that we currently can apply to contain the disease. As such, we are pressed to be a little bit more aggressive when there is disease that can be seen and can be resected. At the end of the day, if the tumor is too diffuse in the liver that cannot be completely resected, one could entertain liver transplant. That said, this is rather controversial at this point, and for many different reasons I don't have time to go into it. They do not usually would fit in within what we call the Milan or the UNOS criteria currently used. But there is no strict criteria. It all depends on the individual transplant center. And in many cases, we have to resort to what we call live donor liver transplant for situations like this. And in summary, I just want to emphasize that surgery currently remains the mainstay of fibrolamellar treatment. Candidacy for surgery depends on mostly tumor-related factors that I have outlined. And we, again, want to re-emphasize the importance of a multidisciplinary evaluation for this particular disease. And it is in that particular setting that the Fibrolamellar Foundation is very helpful to help guide patients to these centers that are familiar with this disease entity. I'll stop there and thank you for your attention.
Thanks so much, Dr. Yeung. What we'll do at the end, for those of you in attendance, is we'll facilitate conversation and questions. I will facilitate conversation and questions with each of the panelists. But for now, we'll run through to the next presentation by Dr. Schadde.
Yes, thank you. Thank you, Allison. Thank you, everybody at the foundation. Let me just get my slide. So, yeah, so I'm going to continue where Raymond just stopped and say that we have a recent experience only with fibrolamellar, and I kind of stumbled into it personally because Paul Kent, our pediatric oncologist at Rush, has been involved with these patients for a while. And I'm very interested in what I call regenerative liver surgery, which means making the liver bigger prior to resection. Is one of the things that Raymond didn't explicitly mention, but I'm sure he's doing as well in Washington, is portal vein embolization, to make the one part of the liver bigger by embolizing the other part. And so when you have liver tumors that are large, that is sometimes necessary and helps. In Rush, we have seen over the last 5 years about 68 patients with fibrolamellar. We have done surgery, performed surgery on 19, and now you're going to say, well, that's surprising because Raymond just said that 70% of patients are resectable. Well, we see a little bit of a different patient collective than what Raymond just alluded to. Our patients have basically, most of them have advanced disease. And I show you that on the right side here. When you look at the right side, we have 19 resections. Primary resections performed in 11 patients, resections for recurrence in 8 patients, and 16 of our 19 patients had advanced disease. And only 3 had localized disease. So what Raymond was alluding to, those 70% that should be resectable by a standard hepatectomy, isn't quite what we see in a referral center. And I'm sure, I just saw that Jean-Nicolas Vautet is on the call as well among the audience. I'm sure that's the same for MD Anderson, the same for Sloan Kettering and other major cancer centers that are treating HCC. That most of our patients are those patients who come and they have advanced disease. Now, Raymond alluded to the fact that we are more aggressive in resection than we would be with standard HCC patients, and I want to support that. I want to go a little bit further and say that we are maybe more aggressive than we are with most cancers due to 2 reasons. First of all, these patients are young, and as Raymond already said, there's no real good systemic therapy that we know works for them. And one of the reasons why we should be aggressive, I think, both in systemic therapies as well as in surgery, is because they're so young that they can actually tolerate resections better than older patients could who have cancer. And you know, the majority of the cancer population is older. I can't really tell you about our survival quite yet because it's been a very recent experience, and I don't want to say too much here. But let me say one word about the importance of surgery. There's very few data, as we all know, and there are some series that are really interesting and impressive, and certainly one of them is the MD Anderson series that were published, and here is the very famous 94 cases series, and they did a univariate analysis here in this table, and they found that certain tumors had a worse survival, were more difficult to treat and had a worse survival. And those are certainly the cases that present as metastatic disease, where there's tumor outside of the liver. And that's a major problem in fibrolamellar HCC. And then there are those cases who have macrovascular invasion, as you can see here, which means where the vessels of the liver or even outside of the liver going into the liver are involved. And then all those patients who have nodal metastases, which is why Raymond just stated it's important to resect all of the lymph nodes, not just for staging, we think, but maybe also because a lot of those nodes will actually recur after resection if they're not extensively resected. And as you all know, there's really no complete lymphadenectomy for the liver because there are lymph nodes all over the place in the porta hepatis, and they go into the retroperitoneum. And if those nodes are involved, you cannot remove them all, but you can remove the ones that are large, and you can remove certainly the majority of the nodes going into the liver. But in order to perform a complete lymphadenectomy, you would have to resect the biliary system, the biliary tract, the bile duct in every case, which we don't routinely do. So in my opinion, and that's a little different from what Raymond said, is I think the real surgical problem of fibrolamellar HCC is not the patients who have liver-only disease. And that's, for me, the reason why transplantation doesn't really help much. There's another reason why I think transplantation doesn't help much, and that's because it kind of obviates the opportunity to give immunotherapy. And we think in our group that immunotherapy is an important element of treating this disease. of course, you will say, and everybody knows that, you know, of course, the patients who had surgery also had a survival advantage, but those are likely the patients at MD Anderson that were resectable, that were chosen for resection. And so this is a bias, which obviously is involved in every retrospective case series like that. And there's no argument against that. But there are some hints that surgery is helpful even in advanced disease. And that's why I chose in my presentation, differently from Raymond's a little bit, to talk more about advanced disease. And we've been seeing a lot of patients in the last few years. And as you can see from my first slide, we didn't operate on everybody who we saw at Rush. 68 patients, we operated on 19. So that's not even 1/3. So we are not super aggressive, but I think we're reasonably aggressive to take patients on who have advanced disease. And from that experience, I wanted to share with you these 5 pictures of the patterns that we have observed in advanced disease, because that may be helpful for the patients in the audience, for the doctors in the audience who are treating patients with fibrolamellar HCC, and maybe for everybody in the foundation as well. So one of the first problems we have encountered that frequently is considered unresectable in other hospitals when patients come to us is when patients already have bulky lymph nodes at the time of diagnosis in the imaging, in the MRI or the CT scan, and these bulky lymph nodes are pressing on the vessels. And Raymond just showed a nice MRI demonstrating exactly that the vessels were compressed and small. And this can be so extensive that it's really difficult to get these lymph nodes off these vessels. And sometimes, as Raymond alluded to, these tumors are invading the vessels. In those cases, the vessels have to be at least partially resected. We're very conservative with resection. And we have found that the majority of the bulky lymph node cases that we've seen, and this is shown here, these big nodes in the hilum of the liver, actually can be scraped off, can be taken off the vessels very well if these vessels are stented prior to the surgery. So we frequently perform portal vein stenting prior to performing these resections to avoid having to resect large amounts of vasculature going into the liver, which we think adds to morbidity. And in a disease that has 100% recurrence rate, which is what I would call fibrolamellar HCC, except for those cases that are very small and limited, that is, I think, the better option. The second type of...
Erik, I just want to interject. I want to be mindful of the time. So if you could wrap up in the next minute so that we have time for the other presentations and interchange between panelists, that would be great.
Yeah. So the second type we saw is the regional lymph node involvement, and that is common. And that's usually regional lymph nodes in the abdomen, and there's no real difference between regional and local lymphadenopathy in classical HCC staging. And we actually take those cases on as well, and we take them on as recurrence cases as well, and remove those nodes. Then we see frequently costophrenic nodes in the chest of the patients that are draining the superior parts of the liver. And so those are regional nodes that are very common, and very common also in recurrence. The fourth type we see are lung metastases, and the fifth type we see are peritoneal metastases. And I want to emphasize that all these 5 types of involvement of advanced disease can be resected, and whether a resection in these cases contributes to the long-term outcome of patients, we have to see. But we think because they're young, they deserve a chance and have that done. I do, however, not think that this should be done in isolation. We are convinced that in our experience, we are convinced that it's important to both use induction therapy and to also use neoadjuvant therapy in cases that are clearly resectable. Induction means you intentionally make the tumor smaller. And in both of those arms, both in resectable and advanced disease, we put them all on adjuvant therapy with the therapy that was first established at MD Anderson, which is the 5-FU interferon nivo, which now thankfully there's also a trial at MD Anderson, which I think is a great achievement. And then they follow very close surveillance. And I'm just mentioning this because I want to make sure that it's understood that I am opposed to putting patients who have advanced disease in a chemotherapy trial with a single agent, because I do not think we provide them the best chance that they have in a disease where we know that resection is a key component of their treatment.
Thank you so much. And again, apologies for the interruption, but I want to keep us on track. Just as a broad overview, I think our take-home message from both our surgeons, and thank you to you both, is that while surgery is undoubtedly the thing tied to success and with the most data at present. And we rely on surgery so heavily because so many of our systemic therapies don't have reliable enough data. And yet there is some existing data, both in the pediatric and the adult worlds. And so I want to next turn over to our adult oncologist, or our medical oncologist, Dr. Gordan, to hear a little bit about the existing trials and his go-to approach for adult patients from a systemic therapy perspective in concert with surgical resection.
Great, thanks very much. And I think just to sort of pick up on two of the themes that have, I'm sorry, I should introduce myself. My name is John Gordan. I'm a medical oncologist at UCSF. I treat patients exclusively with liver cancer, including all of the patients who come to UCSF with fibrolamellar liver tumors who are adults. I have a colleague in pediatric oncology who treats the patients under the age of 18. And I think one of the themes that I'm going to pick up on is seeing how adult and pediatric treatment practices are actually quite different in many cases. And I think one of the things that we are interested in doing, and I appreciate all of my colleagues on this for sort of being open to working together on, is finding ways to unify those strategies right now. And I think just to pick up what Dr. Schadde and Dr. Yeung said as well, for me, based on the available data, based on what I can expect from systemic therapy for my patients, my primary goal in starting systemic therapy is often to get a patient who is not currently a candidate for a surgical procedure to a surgical procedure, or in the cases where surgery is not deemed to be feasible or helpful, then to maintain quality of life for as long as I can. But I certainly agree, and if I would send any one message, it's to consider surgical options frequently throughout the care of every patient with fibrolamellar liver cancer. And so I'm going to focus in this presentation on two kinds of therapy: targeted therapy. So this is a kind of therapy that is directed at the genetics or growth mechanism of a cancer, and immunotherapy, which are therapies that are designed to help the body's immune system recognize and eradicate a tumor. As Dr. O'Neill talked about earlier, one of the things which has really stood out about fibrolamellar is the presence of a very, very frequent single genetic event. And so there are other cancers like this out there. Probably the classic is something called chronic myelogenous leukemia, which led to the first targeted therapy. There was a gene fusion, we could make a drug for it, and that changed really changed the face of therapy for that cancer. Unfortunately, it is thought quite broadly that PK inhibitors targeting the direct fusion oncogene that is seen in fibrolamellar liver cancers would be too toxic for humans because of the important roles of PK in the rest of our health. And as a result of that, much of the work that has been done in targeted therapy for fibrolamellar liver cancers is instead focused on what is between pKa and helping this cancer grow. So there are 3 studies that have been completed in adult populations. There was one study that was run more than 10 years ago, looking at either a small molecule inhibitor of the kinase mTOR or anti-estrogens, or both. This was actually the first study that was ever reported in fibrolamellar liver cancer in adult populations, and it actually just gave us a sense of what to expect. Unfortunately, it didn't actually give us anything useful therapeutically, and those are agents which are not being studied further. A second study of an aurora kinase inhibitor, ENMD 2076, was completed about 4 years ago. And this was encouraging in that we did see some patients who benefited. And I've summarized the details here, but it's also inadequate from our perspective. And so by and large, this therapy is not being pursued further. The final study, which has recently sort of completed its initial phase, but is still ongoing, is of a drug which is actually used across multiple adult cancers called neratinib. So neratinib inhibits the signaling of growth factor receptors, including both the epidermal growth factor receptor, a target throughout many different cancers, and then HER2, a target that we most commonly see in breast cancer and gastric cancers. Neratinib on its own has not been very encouraging, but there actually has been some work ongoing, primarily at Sloan Kettering, looking at combinations of neratinib that I think perhaps will be covered in a later session, which is of some interest. And so I think, unfortunately, even with all of the great progress that has been made in understanding this disease, I think from a targeted therapy perspective, we're still looking for the right target. I think the place where we've seen greater promise has actually been in immunotherapy. So as Dr. Schadde referred to before, 5-FU and interferon has been a chemotherapy immunotherapy combination where interferon is a signaling molecule that activates the immune system broadly throughout the body. There are not comprehensive data that I was able to pull to report here for this combination, but it has been encouraging. And as Dr. Schadde mentioned as well, MD Anderson has started now a study of 5-FU interferon and nivolumab. That's the little asterisk down here. Otherwise, there's a study open at Dana-Farber, actually run by Dr. O'Neill, also at UCSF, treating patients up to 30. So I believe the starting age for this is 12, although I could be wrong on that. But I've been able to refer a patient to this study, and I think it has been, I think that it is a valuable thing to have access to. And this study is the PD-1 inhibitor pembrolizumab, also called Keytruda. And then finally, at Johns Hopkins, there is actually an augmented immune therapy study, nivolumab, which is pretty similar to pembrolizumab, in combination with a second immune activator called ipilimumab, and then a peptide that is actually seeking to target the fusion directly. And then I think in my final comment, I'm just going to sort of try to get this queued up for a transition to Dr. Geller. So chemotherapy, I'm afraid, is still the cornerstone of a lot of what we do. And in the adult setting, it's typically GemOx, and I know that people at Kent and other places have looked at GemOx in combination with lenvatinib, which I don't have personal experience with, but has certainly been reported to be helpful as well. In general, adult oncologists are a little bit less aggressive with chemotherapy than pediatric oncologists, in large part because of what adult patients can tolerate, which is typically less than pediatric patients, even within the young adult ranges that are seen in fibrolamellar. And chemotherapy is really something that I view as part of a multimodal protocol, just trying to get a patient to the place where we can offer a surgical intervention. And I think with that, I'd like to turn this over to Dr. Geller, and just to point out that, once again, you know, we're operating off of case reports and case experiences and individual providers' expertise. And I think some of the pediatric work is really moving towards a data source that will actually be quite valuable going forward.
Thanks so much, John. That was a great introduction for Dr. Geller, our pediatric oncologist on the panel.
Well, I just want to thank, like other panelists, thank the Fibrolamellar Foundation for inviting me to speak and to pulling together such a strong panel of different opinions and different approaches, and Dr. O'Neill for shepherding us through this. I have enjoyed hearing the other panelists, so I do want to thank them directly. I'm not here representing an institution, but rather a cooperative approach. The AHEP 1531 protocol, or the Pediatric Hepatic Malignancy International Therapeutic Trial, or FITT for short, is a trial that Dr. O'Neill and myself and others, including perhaps several dozen surgeons and 3 or 4 dozen oncologists throughout the world, including Europe and Japan, spent some time building. And while we didn't have a HCC or fibrolamellar specific arm in the last trial run by the Children's Oncology Group, we were successful in incorporating such an arm in this trial. The next slide, please. So this is a bit of a busy slide, but I will tell you that I want to echo the comments that you've heard thus far, that the care of patients, whether they're children or adults with fibrolamellar, should include both systemic therapy as well as surgical therapy when perceived indicated. It is perhaps controversial. This, what I'll point to you is this group E arm are on the left-hand side of the screen, are for patients who have upfront surgery and their tumor is completely resected. There are 2 subarms in that group because we do include hepatocellular carcinoma, which sometimes in pediatrics is associated with an underlying disease. And we know that those patients actually do quite well without any further therapy. For those that have de novo HCC or fibrolamellar, those patients are non-randomly assigned to get 4 cycles of adjuvant chemotherapy. And here we use cisplatin and doxorubicin. I'll talk about that in a second. Unfortunately, like Erik's experience, our experience in kids is that most patients don't have resectable disease at presentation, and they go on to group F, where they are randomized to either cisplatin doxorubicin with sorafenib, sort of like lenvatinib, it's an anti-VEGF based therapy, or they're randomized to cisplatin doxorubicin alternating with GemOx, also with sorafenib. If patients receive a course of therapy, which is 8 to 9 weeks, and then they get reevaluated, at which time we strongly encourage consideration of local directed therapy, such as TACE or TARE, which is Y90, or surgery if possible. It is optional to go on to a second course of such chemotherapy. And again, at each branch point where you see an arrow, we encourage that a multidisciplinary team consider surgery, which we all have learned tonight, if not before, is critical for such patients. So this is a chemotherapy-based trial that integrates multidisciplinary input and was designed collaboratively across different disciplines. And the next slide, please. So why cisplatin doxorubicin? You haven't heard that mentioned yet tonight. And this goes back to traditional care in pediatric hepatocellular carcinoma. In the old trial from the intergroup, when CCG and POG, the two former groups that bonded and became the COG, ran a trial in the 1980s and 1990s, and Dr. Katzenstein published the data in 2003. And in that report, we had 10 patients with fibrolamellar cancer, and their outcomes were not different to those who had hepatocellular carcinoma, either their survival or their response to chemotherapy. There were responses to chemotherapy with cisplatin dox, and that those anecdotes and those stories have persevered in the minds of many pediatric oncologists. The challenge is it's not the best tolerated therapy, and I think we are all aware that something more gentle. So myself, Dr. O'Neill, and others proposed GemOx for fibrolamellar as well. If we go to the next slide, we colleagues that GemOx was active in pediatric HCC and fibrolamellar before we could actually launch this trial, including it. So we pulled together and we did a questionnaire. Dr. O'Neill, myself, and others participated, and ultimately I don't remember how many physicians responded, but only 8 physicians had patients, including 24, which included 14 with fibrolamellar treated with GemOx. And actually the response rate in HCCs and fibrolamellar were, I don't want to say encouraging, but we did have 2 objective responses in fibrolamellar, and 6 others had disease stabilization. So 8 out of the 14 with fibrolamellar, mostly pediatric ages and young adolescents, derived some clinical benefit. And this was enough to convince the international community that it warranted a place in pediatric HCC and fibrolamellar carcinoma. The next slide. So the white box shows the enrollment in the United States. The trial is open at over 150 centers, pretty much every state in the country. And so far in the United States, we've enrolled, I think that's about 36 patients with HCC or fibrolamellar carcinoma. About a third are fibrolamellar. Internationally, we've accrued about 69, and I'm sure this is above that. This is as of last month's cutoff to this international study, which collectively is open at more than 400 centers worldwide. So the next slide, please. I do want to acknowledge both Dr. O'Neill and Dr. Rangaswamy, initially at Stanford and now at UCSF, who participated in developing the AHEP 1531 study, which I've been honored to be able to chair. Dr. O'Neill and Dr. Rangaswamy specifically had a role in the HCC and fibrolamellar treatment arm development. But as you can see, there are an enormous amount of people that were involved. And actually, this is about 1/10 of the group that was involved in developing the trial. And the next slide, please. So these are the contacts. We do have a surgical chair, Dr. Greg Tiao, who's both a pediatric surgeon and transplant surgeon, myself in oncology, Dr. O'Neill, Dr. Rangaswamy for a specific subarm. And then there's also surgical chairs, vice chairs in pathology, radiology, and so on, and biology. It's an integrated trial. And we hope that this trial will develop evidence-based medicine. I do want to comment about the immunotherapy. I'm also participating in Dr. O'Neill's study with pembrolizumab and do support it being studied. But I want to emphasize on evidence-based medicine because there is no proof that it really has a large impact on patients' lives yet, nor have we proven that surgery in the metastatic setting has a large impact on patients' lives. So I think we need to take some of the comments we've all shared, and perhaps we'll discuss that as a panel in context. I think the best way is to come together like the Fibrolamellar Foundation is forcing us all to do, and facilitating that we can do that, to collect data together so that we can better inform our community. So again, thanks for the opportunity to speak and to share our international study.
Thanks very much, Jim. I would say in the next 15 minutes or so, I'd love to kind of bounce a few questions off of our panelists. And in being cognizant of the time, I want to really direct a couple questions to our surgeons and then a couple questions to our oncologists. And that might be the simplest way to do things, just in light of the nuances to the questions. But for surgeons, I think it's undoubtedly true that surgery is of utmost importance. And as you have both stated, it's so difficult to extrapolate overall outcome based on surgical intervention. I think and part of the reason is because we know that the systemic or the oncologic care is a very important aspect, and we haven't yet found the right agents to control systemic disease apart from surgery alone. But going forward, what would you propose to be some of the best ways to study surgical endpoints? Are there ways to really better understand some of the nuances to the more aggressive surgical approaches we entertain? And by that same token, should we be considering, for instance, injecting more interventional radiology approaches? So for instance, while we're doing a regenerative approach to grow an aspect of the liver, should we be concomitantly treating the tumor with a TACE, a Y90, or other approaches as we then kind of wait for the next step? So Ray or Erik, I'd love to hear your thoughts on that individually. Ray, would you want to go first? I know you have to depart us early.
Sure, happy to take a stab at this. Yeah, I think in my experience, as Erik alluded to, there are two sort of types of patients that we encounter. Those with disease confined to the liver, which is probably the minority overall because they tend to present late. Those are usually controlled with surgical resection alone. And in my experience, the biology of that seems to be also different compared to the ones that have presenting with nodal metastasis or peritoneal metastasis, which is the two most common route of spread. Those I don't feel that I cure any of those patients. We're just simply controlling the gross disease to try to prolong the natural history by whatever means we can. And it's really up to the medical community and our radiation oncology folks to try to combine these modalities to benefit these patients. I actually have a related question to Erik. That is, I'm interested to hear your thought about the type 5 that you presented with the diffuse peritoneal lesions that we commonly see, and we just don't have a great way. Should we approach this like as if it were a HIPEC approach with maximal debulking and intraperitoneal chemo?
Ray, thank you for that question. Let me answer that first. As you know, even in colorectal cancer metastases, where we have the most experience in HIPEC, there is a big question whether the debulking or the chemotherapy is the effective element in the treatment of peritoneal carcinomatosis. That's from the adult literature. So I personally don't think we need to speculate about whether mitomycin added to debulking helps. Certainly debulking helps to reduce the tumor mass that patients have. There's no question, and debulking can be done. If it can't be done by you, it may be possible for me to do it, or if it can't be done by me, it can be done by Tom Cato at Columbia. We just have a patient who went to Columbia because I sent him there because I wasn't comfortable doing the peritoneal debulking. And Tom just, did it successfully and rendered the patient at least macroscopically tumor-free. The thing that's important to me is I don't think there is a difference in biology, what you just said, between the tumors limited to the liver and the tumors metastatic, because fibrolamellar HCC is a systemic disease. And we need to be clear about that, which is why we need oncology to find an effective systemic cure. But what we don't need is silos of treatment approaches that say, this patient is not resectable. Because what I do in these patients, there's those 5 types I just showed you, Raymond, is debulking. I have no delusions about the fact that I'm just debulking the tumor. I reduce the tumor load. And I think it needs to be multidisciplinary to add that as another answer to your question about the interventional radiology and multidisciplinary approach. We have sometimes debulked tumors inside of tumor masses without ablating the complete lesion just to get them smaller. And yttrium is, by the way, nothing else than doing that. Whether it's yttrium or whether it's portal vein embolization when you have large liver tumors, I don't really personally think it's important, but I think I frequently combine both. So I treat the tumor in the affected site with yttrium, and I do portal vein embolization at the same time, sometimes even hepatic vein embolization, what we call double embolization, which is one of my interests, to make the liver bigger and kill the tumor at the same time. But these are technical questions. I think we need to resolve them among ourselves as surgeons. The important message for me is it's a systemic disease. It has 100% recurrence rate, even if it's limited to the liver. Very few patients can be absolutely cured. Cured should be defined at 20 years. They're late recurrences. We know all of this. But all of these patients remain treatable surgically. And we should just not say at one institution, this is not resectable. That's my main message, that we should just, if we don't feel comfortable resecting, taking a patient on who's young, who can tolerate a resection, because they all can, in my experience, that most of them can, we should then refer them to another place that is comfortable doing that. And I do that with Columbia all the time.
Yeah, I think there's no doubt a collaborative and even multimodal approach, as you describe, is an important one. I want to touch on something you said regarding biology and turn a question over to our oncologists. I think one of the, and I will say, I think going forward, if we could think collaboratively about a way to better study surgical endpoints, interventions, et cetera, I think it would be very helpful in terms of even strengthening further the surgical community pertaining to the treatment of this disease. But the question about biology, I think, is a very interesting one. I think undoubtedly we have been faced with patients in our personal practice where disease is quite indolent and 5 or 6 surgeries cure the patient over the course of 5 to 10 years. And other patients, the disease grows rampant. And I don't know, Ray, if that's what you were alluding to with regards to concern for biology. And I think where we've been limited thus far is our inability to collect massive number of samples and really understand the biology at a very granular level. And one of, I think, and I speak with a bias, one of the strengths of the FITT trial and hopefully other trials going forward are these embedded kind of biologic aims that allow us to really study the tissue better. And so my next question to John and Jim is, talk to me about the importance of clinical trials and where you see the future of clinical trials going for this disease. And B, do you think we'll get to a point where we can agree upon a backbone for this disease with perhaps swapping in cassettes of layered therapy to better understand in a more quick and efficient fashion how to approach the treatment of this disease going forward? I don't know who want to take, John, do you want to go first?
Sure, and that gives me the opportunity to pass the really hard stuff to Jim, so I think that'll work out quite well. No, I mean, I think you've asked the $2 million questions, right? What is the path forward for advanced therapeutic development, and can we reach a consensus? And so, I think that for developing precision therapies for fibrolamellar, I think that we will always be operating at a balance between the available therapeutics and the unique biology of the tumor. And so there are a number of efforts underway to identify repurposable drugs for fibrolamellar, and that's what you've seen in the clinical trials to date. We look at the biology of the disease, we look at the drugs that we have, we see if we can make a match. And this has been a short-term path to try to provide some benefit where there were no options. I do think that in the long term, there is a lock to be found and then a key to be applied to it. And I think, unfortunately, we don't quite know what that is from either an immunotherapeutic or a targeted therapy perspective. I'm encouraged by the fact that we are collecting data around immunotherapy, which I think will give us a sense of whether PD-1 on its own is sufficient, and if not, what should be added to it. I think that will clarify what is done more broadly. But I think that consistent investigation to identify the mechanisms of response and resistance are necessary. For developing a backbone, I think that's essential, and I think that might be a place where pediatric oncology will lead the way, in part because of its better organization and in part because of the relative incidence. But I think that's a fantastic goal, and perhaps I can turn it over to Dr. Geller to comment on how we're going to get there.
John, thanks for that layup. I don't know that I have a great answer to a very good question. I do want to combine your question, though, with your question to Erik about the ability to ask surgical questions. The Children's Oncology Group Liver Tumor Committee, the former chair who helped us through the years of developing the FITT trial was a surgeon herself. And the emphasis of integrating surgical input has always been a priority. And actually, particularly for the Liver Tumor Committee, and the next trial, we're hoping to develop surgical directed questions that can develop the evidence-based guidelines that would help, for example, in Erik's campaign to encourage surgeons to be more aggressive. I think we all face these situations, perhaps those on the panel are at larger centers and we're a bit spoiled that we have some understanding and willingness to be aggressive and so on. But, I don't always think it's a question of, is it resectable? I think the different question is, should you resect, even if it's resectable? And that's where there's some ethical differences. And that's where a clinical trial could really help us as a community dialogue better between oncology, surgeon, and patient to understand when a surgery is indicated and when it's not. Will it help? Will it not? And I hope that the data that's coming out of the West and out of Rush and elsewhere can move the field forward in helping us understand its benefit. I think if we can show in an organized way, however, on a clinical trial, rather than via institution, that surgery makes a difference in certain settings, it would go a long way to pushing people to a certain direction, rather than people getting on their speaking at forums like this and suggesting things. The clinical trials have the opportunity for us to know something rather than think it. And that's where I think the trials can be very powerful. As far as the biology, I think we've all seen some work in this potential second hits that could occur beyond the typical fusion, and whether that drives clonal selection and evolution and changes in clinical patterns. I think that's ripe for exploration. And thankfully, with the support of the Fibrolamellar Foundation, many of the labs at some of the centers that are represented by the panelists here and elsewhere are working hard at trying to understand its biology. So I think that's a huge plus to the foundation and its support. And I do think that will help us develop drugs to combine with the surgical innovations.
Thanks, Jim. I think to conclude the moderated portion of tonight's session and to move on to the Q&A, I just want to paraphrase or perhaps quote what you just said, to know something other than to think it. I think we are at a very fortunate time in medical history and in the history of fibrolamellar study to come together as a community and to really set forth on prospective application of science, clinical objectives, surgical objectives, et cetera, to really come to conclusive endpoints about what makes the most sense as we enter the next decade, and to try and make more substantive and concrete progress with larger numbers for our patients. So I want to thank you for that. I'm gonna write that quote down. But I'll turn it over next to Mark Furth, because I know he's going to lead the Q&A section. It looks like we've got a few questions in the text box, and we'll go from there.
Thanks to all of you for a really enlightening set of talks and discussion. I'd like to start the questions with one first directing to Erik. And I'll combine two questions. You've already said, Erik, I think that you view fibrolamellar carcinoma as a systemic disease. And for individuals who've had surgery as their only therapy up to now and who've been disease-free for a period of, maybe up to a decade or even longer, what is the risk of them eventually having a recurrence that becomes threatening? And what is the philosophy on whether you would treat during an extended disease-free period? And a somewhat related question on the other side is, if you're doing surgery, is there some risk that either through an inflammatory reaction or some other aspect of the surgery that you could actually risk spreading the disease?
Yeah, Mark, thanks for those questions. Let me take the last one first, the spreading of the disease. So I think every surgical event is an immunosuppressive event. And I do think that immunocompetence to the tumor plays a role in treating or in guiding patients along with this disease. So I think it can be detrimental to do major surgery, especially when you have complications. And I've had complications, and they were devastating for the patients and me, and we suffered through them. And fortunately, nobody died, but we've had patients in the hospital for many months, and I don't think that was helpful. And so I'm constantly calibrating the limitations of what I can do, just like oncologists calibrate the limitations of what they can do in terms of toxicity. I have my toxicity, Allison has her toxicity, and James has his toxicity. You guys got to admit that chemotherapy is not without any side effects. And we know that, and patients suffer from it. So do they suffer from surgical complications. So I am fully realistic about that. Your first question, Mark, is the question about, can you have a recurrence of, although you resected and you're tumor-free for many years? Absolutely, sure. I think it gets less and less common. It's really difficult to come up with data on this, but I would not consider a patient with fibrolamellar HCC cured until 20 years after he's been NED last. I am convinced that the idea of MD Anderson in 2002 in their famous interferon alpha 5FU paper has been a very consequential one, not just for HCC, not just for fibrolamellar, but it's a very interesting idea to stimulate the immune system. And I think only through the advent of nivolumab and other checkpoint inhibitors, Pembro, we have actually been able to utilize that potential of the immune system adequately. And so while I do not disagree with studying things like Pembro and Nivo, I would not study them as monotherapies. I have a patient who was started on this therapy in 2002 and is still alive with 5 recurrences, 8 resections, and several ablations. And she just recently gave birth to a child. She's now 34 years old. And I think this woman has immune competence against the tumor. And she was given 5FU and interferon in 2002. And people may smile about 5FU and interferon, but I think it was an ingenious idea by the MD Anderson group, because 5FU's effect is really not, as you know, an cytotoxic effect, a cytoreductive effect, but an effect on myeloderived progenitor cells that play a role in the immune response. So we are using this as adjuvant therapy for 2 years, and then we do close surveillance. So I think close surveillance, you can argue how frequently, is very important for 20 years after you've done a successful resection for the tumor, but I would never advise to a patient not to do adjuvant therapy. Is our evidence great? Of course it's not. But I do think when I look at a trial like the Aurora kinase inhibitor trial that was recently published, and we know the data, that is great medical evidence. Did it help any of the patients enrolled? No, it didn't. Did we need 36 patients to find that out? I'm not arguing against evidence. I'm just saying, let's be a little bit more pragmatic and more flexible. I am fully for prospective data, but not the way they're acute, not the way we're trying to get them right now. Gemox alone is not an option for a patient with fibrolamellar HCC, in my opinion. So is Pembro alone, nor is Nivo alone. So unfortunately, I can't enroll any of my patients that I see. I see mostly patients who come from those, centers and are not, it could not be treated, or they drop out of protocols. But if I see primary patients, I cannot send them to Boston, to Dana-Farber. I cannot send them to James Geller, or I cannot enroll them in these trials because I don't believe that that's the appropriate therapy right now.
And I'll just interject. I mean, I think that the challenge we face in fibrolamellar is that we all have our patients. We all have our examples. I have a patient who's a long-term survivor with single agent Pembro. The clinical trial actually, well, a single agent allows introduction of Y90, radiotherapy, surgical intervention, et cetera, multimodality therapy, and prospective evaluation. So while, I think, and the reason for that study was having cared for multiple patients and having prospective data to support it. So I think the problem we face is we all have our N of 1, 2, or 3. I think that's what prompts us to study patients in an organized and prospective fashion on the basis of our prior data. But what we're arguing, and I think what we as a community need to do better, is to pick a therapy and to organize as a group and to move forward with that therapy before we decide based on N's of 1, 2, or 3 that our data is adequate enough. And I think that's what we're really supportive of.
You know that the Gemox was based on case reports as well, Allison. Absolutely.
And
your Pembro patients are based on case reports as well.
Yes.
I'm fully aware of this.
Prospectively now.
I'm fully aware of this. I'm just arguing for combination therapies for one reason. We don't have time to lose, and we cannot, kind of test the effect of an Aurora kinase inhibitor in 36 patients in order to be 100% sure that it doesn't work.
So if I may interject as the chair of the AHEB 1531 study, I do appreciate your comments, Erik, but I think they're philosophical. I think that when you think of clinical trial and drug advancement, first of all the COG studies that do new drugs are usually Simon's 10 by 10 designs. If you don't see a signal in the first 10, you drop it. So I can't defend a 30 patient study that wasn't justified by some sort of efficacy signal. As far as the combination.
Just a moment. I'd love to get on to some other questions, and this is a fascinating discussion. But I think we're going to pick up more of it, and I think we're getting a little bit deep for some of the patient and caregivers in the audience.
Sure.
I'd like to return to just a couple of basics. I'm not sure we've
Mark, I do think it's important to reiterate the idea that people will counsel with their passions and their thoughts and their philosophies. And what we're trying to do is counsel with evidence. And some passionate voices come out and impact a field. And I think that's okay. It's also okay, as Erik has, to challenge how things are done. But I think that we have to resort back to recognizing when it's not evidence-based advice, it's biased. It's biased by experience. And I think that your audience needs to hear that as well. And I think everybody on this panel is trying very hard to help all of these patients, even if we disagree about how to go about it.
I thank you for that statement. I very much agree that, first of all, everybody on this panel is incredibly dedicated to the patients. We're going to have a full discussion of the whole area of clinical trials in the middle of April, and we'll invite people to come back for that discussion because I think it will pick up on some of the themes that we've already been hearing about. And I know, for example, Paul Kent will be there to talk about the Rush experience, and others who are doing clinical trials, including Ali, will be there.
Very good.
Just to step back and ask if we could get a little more insight on the differences between some of the different categories of therapy and where they fit today. We've heard immunotherapy, for example, mentioned, but haven't actually talked about what it is in any depth. And I think that would be informative for the audience. And also, at least one of our audience members pointed out, we haven't talked at all really about the value of integrating radiotherapy in various ways into the multimodality treatment. So perhaps, Ali, you could help us just get started on some of the definitional stuff, or pick out who in the panel you'd like to have respond to those points.
Yeah, absolutely. I'm happy to kind of pick up on that last piece regarding radiotherapy. I think it is another tool in the toolbox. I think it's sadly one we resort to when we don't have other, what we call local control options. So often in cases where we can't perform an adequate surgical resection, or disease has multiply recurred despite multiple surgical resections, or in the context wherein something like Y90 or directed delivery of chemotherapy has not been useful. Radiotherapy is always a consideration. I think it's always in the list of things that we will employ concomitant with other treatments like chemotherapy, like immunotherapy, because each tend to work better in combination than they do alone. And that kind of harkens back to the recurrent theme in our conversation. So I do think it's relevant to keep in our list of options and to consider combining with therapies as we go forth. Jim.
Yeah, Mark, it's a great question. I don't know about others' experiences. I'd be curious to hear. We're never happy with a positive margin, right? I think the surgeons can comment on this more than myself as an oncologist, but where I've used radiotherapy in a few patients actually is when they have non-metastatic disease, they were not candidates for transplant for various reasons, and had a gross total resection with a microscopic margin in one area. It's not always the most gratifying situation. And for example, along a bile duct or some anatomical area where you really can't go back in. And we have used proton radiotherapy in a number of patients. In fact, that's permitted on the international trial we talked about after the first course. And I know a few patients who've been on that and went and had their margins radiated. I agree with Ali. Sometimes it's reserved in the palliative setting for local control and pain control, but I think there's a role, and we probably should study it a little bit better.
John, in your practice, treating adult patients, have you utilized radiotherapy with frequency?
Yeah, I mean, I think one of the sort of themes of this is, just as you point out, the tools in the toolbox, right? So I would say that we have, I think it's very much what both you and Jim said. I would say that my use of radiation therapy has been mostly to manage symptomatic lesions. When we've been in the position of trying to get to some kind of period of disease control that would allow a patient to not receive systemic therapy, I've been more likely to pursue surgery or some kind of local regional therapy. And I think that's been driven by where disease has been as I've faced it and the multiplicity of disease. But I think that there's no question that I've had positive experiences, particularly with SBRT over time. And I think it's all about finding the right tool for the right moment.
Thanks, John. Ali, maybe you could also just, again, give people just a very fast overview of what does immunotherapy really mean? What are some of the categories of that are available today, and specifically available for fibrolamellar, and maybe just a hint of where some of that may be going in the future?
Yeah, I'm happy to. Immunotherapy by principle is reprogramming or reawakening the patient's own immune system to recognize the cancer. I think in most contexts, we think cancer arises in the body because for some reason, the immune system never noticed it. And when that happens, tumor growth goes unchecked. So the primary drugs at our disposal that people keep mentioning, checkpoint inhibitors, are a certain type of antibody therapy. They're designed to bind to a protein either on the tumor surface or on the immune cell itself, and upon binding, re-excite the immune cell. Now, they don't re-excite the immune cell in a purposeful fashion. They don't tell the immune cell, okay, you're excited, now go get the cancer. They just non-specifically reignite the immune system. But in doing so, the immune system then tends to recognize the cancer, whereas it hadn't previously. And so checkpoint inhibitors are just one class of those medications, but there are a number of different drugs that fall into that category. As we get better and better in our clinical research, we've now designed alternative means for immune therapy. Erik had mentioned the prospect of interferon in combination with 5-FU as being a partial immune stimulant. And the question of whether nivolumab enhances that immune stimulation further is really best answered by the clinical trial that MD Anderson will run going forward, because that'll be able to accrue enough patients to tell us whether addition of nivolumab does more than those two drugs alone. But again, there's more and more research asking how else can we ignite the immune system more purposefully. The trial that Dr. Martin Yautron is running out of Johns Hopkins intends to, and I know that John, you mentioned this, give a vaccine to really program the immune system to look for specific aspects of the tumor right before igniting it. So I think as we learn more about immunotherapies, we'll be better able to not only excite the immune system, but do so in a purposeful fashion. Now, that doesn't come without toxicity. Anytime you ignite the immune system, you inflame the body. And so that kind of harkens back to some of the conversations we had with Erik too. You know, inflammation is good to some extent, particularly when it's purposeful, but it's probably not the only answer.
Thanks, Sally. I'd like to turn to a slightly different topic, which comes under the sort of rubric of precision oncology or precision medicine for cancer. And there are really a couple of different questions have come through the audience that relate to this. One is, are we potentially going to get to a point where we will have ways to individualize therapy for fibrolamellar? One approach might be testing each person's tumor in different ways. Another might be based on genetic information we have about the cancer. So I'd like to see if you guys have crystal balls about that in fibrolamellar. And also just from the practice, and Erik, this is something I know that your team has talked about a lot, and I think the rest of you have seen. There clearly are differences in the course of disease, both the aggressiveness, the speed, and maybe some other aspects. Even there are subsets of fibrolamellar that have a different genetics and don't have the fusion gene, at least closely related cancers, like the BAP1 class that's been published on from Jessica Zugman-Rossi and colleagues in Paris. So where does fibrolamellar fit into this game of individualized therapy?
Perhaps I can start and then turn over to others. I mean, I think that fibrolamellar has always been a place where individualized therapy has been extremely appealing, in that it is a genetically fairly simple tumor. And it is challenging, as I alluded to before, because we do not have pharmacology that targets its pathway. Like we don't have anything off the shelf to use. But I think that precision therapy for fibrolamellar in general is attainable. And honestly, I think the path there has been supported extremely effectively by the foundation. That's been one of the huge areas of progress. I think individualizing it to patients and understanding these broad differences in disease biology, I think, is a fascinating next question. And I think it's incredibly important because, I think we've all experienced vastly different courses of disease. And I would like to know what to expect. I think my patients would like to know what to expect. And quite often these sort of biological distinctions can be the path to finding new therapies. So I think it's a very important aspect of the near to medium term future.
Mark, you're muted. We can't hear you.
Thanks, Sally. I was going to ask Erik that I know his team has seen quite a large number of fibrolamellar patients over the past few years. You may have as good a sense as anybody of really what that range of different presentations is, and do you have means yet within the approaches you're taking to tailor to the individual patient based on whatever criteria you can find, the presentation, or do you see that happening with genetics or individual testing of tumors in the not too distant future?
Well, I think one of the problems is when you have a trial is that you have very usually strict inclusion criteria, right? And so the patients we see are frequently already being treated with this, and that. For example, what I found disappointing about the vaccine trial at Johns Hopkins is that we couldn't send patients there who've already been treated with nivolumab or pembro, because patients who've already had checkpoint inhibition cannot be enrolled in that trial. And similar to other trials. So I think that we are not in an era right now with fibrolamellar where we can easily just, do these big trials with very kind of exclusive inclusion criteria. We need to be very pragmatic. And pragmatic means that we're going to try a certain treatment prospectively, well documented, and then switch if the therapy doesn't work. Question is always, how soon you switch, what type of response do you expect? And we're looking at objective response. You have 12 patients, for example, treated with Gemox, lenvatinib, that combination that is similar to the combination that you're running in the trial James just talked about, where the sorafenib is part of the Gemox regimen. But we chose lenvatinib because lenvatinib, in the studies that have been done for HCC, has a much higher objective response rate. You know that. And so we also felt that the side effects of sorafenib were detrimental. And so we chose lenvatinib. And we have seen in 7 out of the 12 patients we've treated a partial response by RECIST within 3 months. So that is more than we have seen with any other regimen so far. So we are prospectively, which physicians have done for hundreds of years, prospectively evaluating in a respective way the way we are treating patients within a relatively short period of time, 3 months, 6 months, to see whether the tumors are responding to render them surgically resectable. So that is my approach right now. That's the approach that I would promote in order to have the maximal flexibility. Now, different biology, I don't know. Of course, they're more aggressive forms, and then we switch therapies. And we do that because they're not responding to the therapy we're using, and we're documenting that they haven't responded to, for example, Gemox lenvatinib. Then they get a different regimen. And so we have a multiplicity of tool therapy regimen in our toolbox, just like James has in his trial as well, where there are also a multiplicity of arms, and we're evaluating them prospectively. And that is the way we do it. The only thing I would warn against for the patient's sake is to be too rigid about a certain approach and to follow them too long in a certain line when they're obviously not responding, like was to me obvious in the aura kinase trial, where a lot of patients did not respond. So I don't know, Mark. There may be a more aggressive way of a form, a less aggressive form, etc. I think we need to be very flexible as therapists, both oncologists and surgeons, in responding to the tumors.
If I may just agree with Erik, and in fact, on the way that the international trial is organized, the patients it's response-based outcomes, and after 8 to 9 weeks of therapy, it's up to the choice of the physician and the family and the patient whether they want to get more or do something different. And I think we designed it that way because of some of the things Erik said, which is you need to shift. If things aren't working, don't stay on the therapy. So I like the fact that we're agreeing to this.
I think that this has been a fantastic discussion, and I love that it's been open and people are sharing these sort of cutting edge, passionate differences and with a shared goal of coming up with therapies that really are going to be more effective. One last quick question, and then I'll turn it over to John Hopper to conclude. Looking ahead to our session on clinical trials in a few weeks, a pragmatic question is, are we getting to the point where people can participate in trials, not necessarily going to a center which is one of the hosts for that trial, but on a more remote basis? Is it possible that people can essentially join a clinical trial virtually for this rare disease?
Oh, go ahead, Jen.
Well, it's a really good question, and at least on the international trial, the answer is no, but maybe it shouldn't be no. So I really like the question. And there is an organization, the NCORPS, which is the National Community Oncology Group, which includes about 800 adult oncology centers, mostly community-based, throughout the country, in the US anyway. And when trials are open through certain pathways, one is called the NCTN, which is the National Cancer Therapy Network. through any of these cooperative groups, if NCORPS is included, and if we advocate for that in the future, then it really becomes accessible to about 1,000 different centers in the country. So unfortunately, the answer is no right now that I'm aware of, but maybe we can make it a yes.
Thanks, Jim. I'd like to say I'm sure we could go on for another hour and a half, but we need to be respectful of people's time, especially all of you who've been so kind to join the panel in the evening or late in the afternoon on the West Coast. So please let me say just how much we appreciate what all of you are doing. And let me ask John to just wrap up for us, please.
Yeah, thanks, Mark. And again, thank you, Ali, for leading the panel. Thank you, John, Erik, Jim, and Ray. An excellent discussion. And this is what the community is asking for, is discussions on this. And as I said before, this empowers the patients and caregivers to talk to their oncologist and make the decisions that are right for them. So thank you for the diversity of the perspectives. Thank you for your time on this. Again, a reminder, as Mark said, there is a clinical trial and future therapy panel just like this on April the 14th. I think the other key point there, and I think several of our panelists mentioned this, the involvement from patients, and the more that we can get patient information, participate in the biobanks, so we can look at the different ways that people are responding to treatments, et cetera. That's going to help empower everything that's being done here. So be active in the community as much as you can. Certainly, ask us any questions that we need to. But thank you, everybody, for being part of this. Thank you, panelists. And we hope to see everybody on the 14th. So thanks, everybody, and have a great evening.
Thanks, everyone.